All right, so moving on to Meary's angle. What Meary's angle essentially is just an assessment of the arch. So basically what we can do is through radiograph, we can see if there is any osteological deformities that could potentially lead to an arch deformity. Essentially, what we're looking at here is we're looking at an angle of if it's below 15 degrees, by way of the little red lines you see on the screen, then that's going to be a moderate deformity. Anything 15 to 30 degrees, I'm sorry, under 15 degrees is going to be a mild deformity, 15 to 30 is going to be a moderate deformity, and over 30 degrees is going to be a severe deformity. So this is the case that happened to me a while back. Here we go, we got a 16-year-old football player. He has helmet contact injury, lateral lower leg. Abe will walk in, walks into my clinic, no assistive device, looking good, gait looks good, no big deal. 8 out of 10 pain, and the referral said a calf strain, right? So what I want you to think about is that we're going through some of these cases, we're going through some of these radiographs, why that patient had 8 out of 10 pain with a calf strain, yet he had no gait abnormalities. So what we think about is what views in terms of radiography would be beneficial. Obviously, how does that patient fall into our auto and ankle groups? How does that patient fall into our ACR criteria? So what we see is this patient, when he went in for radiographs, actually had a distal third obliquely oriented fibular fracture. We can see that especially through the AP view and the lateral view. Remember how that lateral view was made, and this is why I brought up that point last week, because that tibia is going to sit essentially on top of the fibula. And you have to understand how that picture is made, because what we're looking at here, especially from the lateral view, is a significant fibular fracture. Now, this is what foot and ankle are going to look like on an MRI. MRI is going to be very important. Like I said last week, what we see a lot with foot and ankle injuries is a lot of soft tissue injury. Therefore, an MRI is going to be very appropriate for a large amount of our patients. Having said that, understand that I can still see a ton of osteology here, right? I can still see a ton. So make sure when you're looking at material, studying for the final exam, or your own edification, please make sure that you know how to label these sorts of images. This is another view. Obviously, we're looking at an axial view of the foot in addition to a planar view of the foot, right? So again, we may have multiple views happening with an MRI. In terms of the ABCs of the ankle and the foot in terms of radiology, obviously, remember what those ABCs are, that A is alignment, B is the bone margins, right, or bone density, C is cartilage, S is soft tissue. What we need to look at here, especially now, we're looking at a mortise view, right? So we have a mortise view up on the screen here. What we need to look at is we need to look at what's called the medial clear space, the lateral clear space, and the ankle joint space. Now, what we should see, ankle joint space should be 3 to 4 millimeters in width, no more. Lateral clear space should be 5 millimeters in width, no more. Medial clear space should be 3 to 4 millimeters in width, no more. If we see lateral clear space increased, medial clear space increased, what that is indicative of is that my anterior and posterior tibiofibular ligaments have been disrupted, either partially or completely, and I have what's commonly known as a high ankle sprain. This is a really good picture of a non-displaced fracture of the proximal tibial diaphysis. As we can see here, great example of why one view is no view. When I look at that AP view, I can kind of see a fracture if I look close. Take a look at the lateral view, that fracture shows up very clearly. Now, like I said last week, a lot of different fractures, a lot of different names. What we're going to see in a lot of reports is we may see a unimalleolar fracture. What that means is that either the medial or lateral malleolus has been disrupted or fractured. If I see a bimalleolar fracture, that means that both my medial and my lateral malleoli have been fractured. A trimalleolar fracture, and this is the fun one because think about it, we only have 2 malleoli, but a trimalleolar fracture is going to be a medial and lateral malleolar fracture and distal tibia fracture, right? So 3 fractures, trimalleolar, even though we only have 2 malleoli. This is a nice drawing of the difference between unimalleolar, bimalleolar, trimalleolar. Watch out for these trimalleolar. Again, make sure multiple views have been done because if you don't have a lateral view, a lot of times you're going to miss that distal tibial fracture. This is how a bimalleolar fracture may look on radiograph. What we're looking at here is an oblique ankle view. What we see is that my lateral malleolus and my medial malleolus have both been disrupted. This is how a trimalleolar fracture is going to look. Now, if we look here, you got to look really closely. What we see is that I have one fracture here at my fibula. I have another fracture here at my medial malleolus. And when we look at the lateral view, you can see there's a posterior fracture of the distal tibia. We've gone over Salter-Harris classifications for epiphyseal plate fractures. A lot of those same rules still apply to our foot and our ankle. So just be aware, same rules, same classification system, nothing's changed. This is a type 1 fracture. Now note, this is a type 1 fracture of the fibula, not necessarily the tibia. Another classification system you may see is a fibular fracture classification system called the Weber system. Weber system goes by type A, type B, type C. The way a type A is classified is a lateral malleolar fracture is below or distal to the ankle joint space. A type B is an oblique fracture of the lateral malleolus through the syndesmosis, or right at the joint space. Type C is above the joint space. Obviously, as you see from the slides, each one of those fractures has associated injuries that we need to watch out for. This is what a type A fracture looks like. Obviously, what you can see here is that my fracture line is well below the syndesmosis, well below that ankle joint space. This is what a type B fracture looks like. Now, the reason this is called a type B is because even though that fracture line is going through just like that, there's going to be a little bit that comes right at the syndesmotic line, right at that mortise joint line. If there's any piece of that distal fibular fracture that is in line with the mortise joint, then we're going to classify it as a type B. Type B fracture again, this is another great look, another really good example. There's that fracture line, but just a tiny piece of it becomes in line with the syndesmosis or the mortise joint. This is what it's going to look like post ORIF. They're going to put some plates, screws, hardware, all that fun stuff in there, and they're going to piece that guy back together. This is what a type C fracture looks like. Now, what we see here, again, still have an oblique fracture line. Everything looks all fine, but that fracture line stops well above the syndesmotic line, right? So there's my end of my fracture line, but yet my syndesmotic line is way down here. Okay, so watch out for these. If that fracture line is way above, way proximal to the syndesmotic line, we're going to classify it as a type C Weber fracture. Another great example of type C Weber fractures here. This actually had a deltoid ligament tear in addition. And how we know that is because I can see increased spacing between the medial malleolus and the talus, right in there. So what I want you to think about is what type of injury would we see? Obviously, this is probably going to be an eversion sprain, right? So the person hit the ground, fibula got shoved upward, snapped, obviously fractured, and then a deltoid ligament tear in addition to that. Another good view of a distal fibular fracture and being a Weber type C. There's another classification system. I'm just going to be honest with you. The foot and the ankle have more classification systems than you could ever shake a stick at, right? So there is a Taylor neck classification system. Taylor neck is going to be the Hawkins classification system. Weber, distal fibula, Hawkins, Taylor neck. Now, what we're going to see with all these three types is that it actually follows a very routine, very familiar system, right? Kind of like your ligament tear system, a type 1, type 2, type 3, or grade 1, grade 2, grade 3. A type 1, we have about 11 to 21% of that talus that's been disrupted with no displacement. Type 2 means we've got about 40 to 42% disruption, and there's some subluxation, and there's some displacement happening. Type 3, that's when everything's gone wild. Talus not only has been displaced, it's actually rotated way off the space and doesn't even look like a talus anymore. This is the type 1. What we can see here is we can see a medial malleolar fracture, and we can also see a Taylor neck fracture. This is where, again, one view is no view. Got to remember that. So what we see here is right there, there's my medial malleolus fracture. Now, what we cannot see from the AP view is we can't see where that talus fracture is. It's not until we actually go into the lateral view that we can say there's a little talus fracture right there. So I want you guys to get a good appreciation for that we need to have several views, right? If my patient's only coming in with one view, then I'm going to miss something. This is a type 3 Taylor neck fracture. What we can see here is that there's total disruption between both sections of the talus. You can see that right in this area here. And that my talus has been totally turned around, and there is a maximum amount of displacement happening there. Avascular necrosis of the navicular is specifically called Kohler's disease. We've talked about a few of those, like with the scaphoid and a few of the carpal bones with things like Kienbach's disease. Kohler's disease is going to be specific to the navicular. Now, obviously, what's going to happen, we can see in very severe cases of avascular necrosis, we can see deformity on radiograph. However, MRI is going to be our go-to. MRI is going to be a modality of choice because obviously you can see from the right-hand side of the picture, I get a really, really clear view of how bad that navicular actually is. This is a good view of a calcaneal stress fracture. Obviously, with stress fractures, we want to go straight to MRI. Now, think about signs and symptoms. Think about how the patients can present in your clinic. We already kind of talked about this. If I do that little calcaneal squeeze test and that patient jumps off the table, probably need to go to an MRI for them. This is a good view of a Lisfranc injury, both from the radiographic side and the MRI. Obviously, what we can see with the radiograph is we can see some disruption, and we can actually see displacement of the lateral metatarsal bones, simply because that Lisfranc ligament has been disrupted. With the MRI, what we can see is we can see disruption of the Lisfranc ligament specifically. Anterior ankle impingement syndrome, another big one you guys are going to have to watch out for. We see a lot of this in the clinic. Typically what we're going to see is that an osteophyte in the anterior edge of the distal tibia. And sometimes you're going to see a divot in the talar neck. So the distal tibia has actually worn away a portion of the talar neck. Now think about this. What types of views are going to be needed to see, right? What types of views do we need? Probably going to need an AP, probably going to need a mortise, lateral if the symptoms lead us that direction. but we definitely are going to need to see an AP and a mortise with this. This is anterior ankle impingement and tibial-talar spurring. You may see this as well. Take a look at both radiographs. And what we see is that the distal tibia has crashed into that talus so much that's actually created some spurring. So what we're going to see is we're going to see our patient present with very limited dorsiflexion, and think about what sort of end feel you're going to have here. If I have very limited dorsiflexion and a bony block, then I need to think bone, right? I need to think there's a reason they call it a bony block, and that's because bone's blocking bone. So if I have an abnormal end feel and it just feels like that ankle comes to a dead stop with dorsiflexion, I need to start thinking about things like this. And I probably need to refer that person out for some radiographs. These are what OCD lesions look like in the talus. As we can see here, and I'll point it out for you, there's a very small divot where the cartilage has been worn away. It's right there in that picture, and it's right there in that picture. So watch out for this, right? That's that patient with really localized signs and symptoms, obviously increased pain with weight bearing, decreased pain with non-weight bearing situations, and they may have a lot of pain when you place that joint in a closed pack position. On MRI, much different picture, much clearer picture, but same result, right? So we still have an OCD lesion or OCD fracture happening at the talar dome. This one's an interesting one, right? So this one, the Achilles tendon has ripped off a piece of the calcaneus. We can see that piece of the calcaneus that's been removed right there. So it looks like an increased area of radiodensity or bone density in a spot where we don't normally see bone. This is another good picture of a calcaneal fracture. If you're having difficulty seeing it, the calcaneal fracture is right there and pretty evident. These are Jones fractures, right? So Jones fracture technically is an extra-articular fracture of the proximal shaft of the fifth metatarsal that is distal to the metatarsal tuberosity. Now, what I'm going to tell you is that clinically, if the fifth metatarsal is involved, typically it's going to be called a Jones fracture. The actual definition is exactly what you see on the screen. In the left-hand side of the picture, the fracture is right there. The right-hand side of the picture, obviously the fracture is there. This is another great representation of a Jones fracture. What we can see is that the joint line is not involved, and I have a fracture right through that base of the fifth metatarsal. So this is an extra-articular fracture, or in layman's terms, not involving the joint space. This is a good graphic representation of the difference between a stress fracture, Jones fracture, and a avulsion fracture. These are typically where we're going to see these located, right? So think about what attaches to that base of the fifth metatarsal, right? Automatically, you should say, oh yeah, it's fibularis brevis. We know that from anatomy. So think about that patient that has an inversion sprain. They come to you with an inversion sprain. After all the swelling has gone down and they're putting weight on it, so, man, I just have this pain in the lateral side of my foot. They could have an avulsion fracture with that. But remember, an avulsion fracture is typically going to be an intra-articular fracture or involving the joint surface. Jones fracture technically is an extra-articular fracture. This is a stress fracture. Obviously, you can't see it, or it's very, very, very obscure. What we can see here is we can see a little bit of a cocooning or a little bit of a calcification surrounding that third metatarsal. Typically, we're going to see stress fractures second, third, or fourth met heads, or second, third, and fourth metatarsals. We see this a lot with folks that have changed some sort of training or progressed some sort of training in rapid fashion. New recruits in the military, very prone to this. Folks that are going out and strengthening and conditioning for a specific sport. Pediatrics, adolescents as well. This is another really good representation of a metatarsal stress fracture. Obviously, what we see here is we see a lot of cocooning happening. We see a lot of calcification laying down to protect that stress fracture site. Now, MRI, going to give us a much different representation, but honestly a much clearer picture. With a lot of our stress fractures we've seen so far, we want to go straight to an MRI for a lot of these folks. There's another great picture of an axial MRI. Obviously what we can see here is a lot of uptake, a lot of action happening right at the second metatarsal, right there, which is why that shows up a lot brighter. This is what a talus fracture can look like on CT. This is straight out of your textbook on axis physiotherapy. And then here's an axial view of the MRI, right? So we see a lot of different stuff happening here. Obviously, you can see your talar dome. You can see things like the ATF ligament, anterior tailfibular ligament, posterior tailfibular ligament as well. In addition to that, you're going to see a lot of those tendons, right? So those Tom, Dick, and Harrys and all that great stuff. This is what ATF is going to look like on an MRI. It's going to be just a little dark area right there. And then this is what an OCD lesion can look like on MRI as well. Posterior tailfibular ligament rupture. Obviously, we're going to see an increased area of uptake, increased area of brightness or density, where we should not see one. And this is what a high ankle sprain is going to look like on MRI. So radiograph is probably going to be a little better modality here. As you can see, the MRI is not terribly clear, but we can use that to diagnose a high ankle sprain. All right, guys, and we got a bunch of references, and that's all we got. Thank you for your time, and good luck with your studies.